and this one should be sigmoid. When we remove this part, then we can find or reach to the rectum. So, as you can see here, transverse colon by its meso divide greater cavity into two parts. Below the transverse colon and its meso we say infracolic, and above of these we say supracolic. So in supracolic, as you can see here, we reach to the liver, stomach, and spleen, and of course pancreas and kidneys, the upper pole of the kidneys, and the suprarenal glands located at the supracolic area. So in infracolic area, as you can see here, we have some, sorry, let me do next slide, please. In infracolic, we have these, I mean all the small intestine by parts or all parts of colic space. This group is right paracolic, because this is a colon, we say paracolic. Right paracolic group, and this one here is left paracolic. I mean, I can push my fingers at the lateral of the descending colon and go up. Here again, at the right of the second and ascending colon, again, we can find a groove like this. Okay? Don't forget. The right, the left paracolic, the left paracolic groove superiorly reach to a ligament that I introduced this before to you. Verticocolic. It means this ligament connect the left flexure of the colon to the diaphragm. So, left paracolic groove from above reach to a ligament that connect left flexure to the diaphragm. The name of this ligament was verticocolic. So, verticocolic superiorly limiting the pathway of the left paracolic to
diaphragm.
To? No.
Thorax.
Thorax, no. I mentioned this before to you.
Can you repeat it?
Look here. This groove on the left and this one on the right. Okay? On the left paracolic groove superiorly limited to a ligament that not let my way reach to which part? Easily, it's so clear.
Kidney.
Which region? Which? No. No. What was the name of this area? Supracolic. And this one was infracolic. So, through the left paracolic groove, we cannot reach to the supracolic region. But at the right paracolic groove directly goes up and without any problem, anything can reach to the supracolic area. Who can tell me immediately after the right flexure which elements my finger touch when I goes through the right paracolic to the supracolic area?
The liver.
Liver is above. Look here, this is the liver. Yes, he is right, because when I go up, we reach to a blind part, recess between the liver and
the right lobe of the liver. Right kidney. Right lobe of the
kidney. Excellent. In another slide, I will show you. When we remove all of this part, you can see the kidney. So, exactly at this part, I mean here, in this point, we have right kidney because it was retroperitoneal, okay, covered by peritoneum. And right and left colic flexure exactly located at the inferior pole of the right and left kidneys. So, as she mentioned, when we go through the right paracolic groove, above of this flexure, the right colic flexure, we reach to supracolic area, and immediately below than the liver, we can touch the right kidney. Here, there is a blank space. There is a recess. That name of this recess is hepatorenal recess.
Morrison pouch. It is Morrison pouch.
It does.
The second name of this hepatorenal recess is Morrison pouch.
Morrison pouch. I will tell you, okay? What happened? Right. Paracolic groove directly reached to the supracolic. Left paracolic limited by a ligament that the name was furnicocolic. And both of these grooves freely reach to the pelvic space. Is clear?
Yes.
If I remove the small intestine, all the small intestine attached to the posterior wall by what? Mesentery. Excellent. If I make cut through the mesentery of the small intestine, immediately we can reach to the infracolic space. Look here. If I made a cut and remove the transverse colon, this one being the attachment of the two layers of meso of transverse colon to the posterior wall. And if I make cut and remove the descending colon, the attachment should be like this. Yes? Because colons ascending and descending were retroperitoneal. Am I right?
Yes.
Imagine I made a cut through the attachment of the mesotransverse colon and remove this. Then, for descending and ascending colon, I should make a cut and remove all of this. Because peritoneum cover these two parts, you can see this space because of attachment to the posterior wall. But transverse colon, because attached to the posterior wall by two layers of peritoneum, the side of this should be like this. And for what? Sigmoid. Again, sigmoid because attached to the posterior wall by meso, the meso should be like this. And mesentery attached to the posterior wall in this direction. Look here. From the mesotransverse colon to the second. And here was that part that edu.m joined to the second. Am I right? So, when we remove all the small intestine by the ascending, transverse, descending, and sigmoid colon, then we reach to this space. Right infracolic space. Left infracolic space. Right infracolic space superiorly reach to the mesotransverse colon. And at the left to mesentery. And at the right to the ascending colon. Left infracolic space superiorly again reach to the mesentery. At the right to mesentery, attachment of the mesentery. At the left to
Descending.
and meso of sigmoid. So any liquid here easily has approach to the pelvic floor. This one is right, please, paracoelic groove that freely reach to the supracoelic. Here we have right kidney like this, and here we have liver that I removed it. Okay, kidney, liver. So this space, this pouch is hepatorenal recess. But at the left, at this part, the left flexure of the colon attached by two layers of the peritoneum to the diaphragm. So we say vernicocoelic ligament. So liquid here cannot reach to the supracoelic, but at the right side, in right paracoelic groove, any liquid, I mean infected liquid that it may be found in body of some person, it can easily reach to the supracoelic, and it will be dangerous because under the diaphragm, the exchange between the liquid and the blood vessels being exaggerated. Yes? So, because of this, if any person, any patient that you face in hospital, if we suspected that there be any infection inside of the abdominal part, we should be keep he or she in the sitting or lying position that the liquid comes here, not reach to the upper part, I mean under the diaphragm. Please review quickly in 2 minutes, and then if you have any question, ask me.
Professor, the space you mentioned, RLS, what's the name of it?
Right
infracoelic
space.
Right infracoelic.
Left infracoelic, right infracoelic.